So good morning to all of you. And Dr. Smith, I want to thank you and the rest of the Rogosin Institute, Dr. Garson, for inviting me and having CMS speak to this august group. It's always a pleasure as a nephrologist. I deal with many, many things at CMS and spend only a tiny part of my time with renal disease and nephrology issues. But these are the love of my life. I've spent most of my life focused on this particular area, so it's a special pleasure to be here talking on this particular topic. The only thing I'm going to need some help is figuring out what I push to advance the slides. Well, there's on the Apple. Here we go. Okay. Thanks. So what I'd like to do in the limited amount of time we have this morning is to tell you a little bit about what's, a tiny little bit about what's happening at the Centers for Medicare and Medicaid Services, to try to apply those activities that are ongoing right now and others at the Department of Health and Human Service and throughout the federal government, to loop those back to the kidney disease world, and then to end teeing up all the other wonderful speakers who are going to be here today with somewhat of a call to action going forward that I think we all need as a kidney disease community to focus on. And the people in the booth, is there a way of putting this up on the screen also so I can see this without having to turn? No? Okay. Well, I've had to appear before 500 people with the screen not working, so this will be relatively easy. Again, this is just to give you background. Most of you should know what the Centers for Medicare and Medicaid Services do, but we are arguably the largest insurance company and the largest payer of healthcare services in the world. As you can see here, we administer health benefits to over 114 million Americans coming up for the Medicare, Medicaid, and CHIP programs. And I've listed for you here the total number of beneficiaries for those programs. In addition, on the bottom part of the slide, you'll see that we have the number of individuals, the amount of money that we're spending for each of these programs. And as you can see, we will be spending in fiscal year 2011 over $784 billion just on these three programs alone. Within the end-stage renal disease world, we spend about $25 billion a year on end-stage renal disease services for the Medicare program. And we spend for chronic kidney disease and end-stage renal disease about $65 billion a year. So just from our programs alone, a humongous number of people and a lot of money being spent. But it goes beyond here because we, in fact, through our activities, largely influence what the commercial sector and many other parts of the healthcare economy do in the United States. We're known for three major functions at CMS. The first, best known one since we started in 1965 when the Medicare Medicaid program started, are administering healthcare benefits for, the three programs that I mentioned before. And in order to do so, there's a tremendous amount of research and other testing and piloting that has occurred for payment systems over the years. And you'll hear more about that because we're on the cusp of a major advance in that area also. We also administer benefits and do increasingly more patient-centered activities for beneficiaries. And as you can see here, we are not only educating beneficiaries about what they're entitled to under the Medicare, Medicaid, and CHIP programs, but increasingly what kinds of behavior patterns and what they should be doing to stay healthy and to take best advantage to leverage those services that we're actually doing. And then last, but certainly not least, is in fact a function that we were not known for, thank you very much, a function we were not known for when the programs first started, but arguably is probably our most important function for the last few years and certainly going forward. And that has to do with multiple strategies to improve quality, efficiency, and value in healthcare. And we'll spend the bulk of our time talking about some of those issues. Now, most people have focused on what needs to be done regarding the payment system. Occasionally people talk about transparency and public reporting. But I listed here what I call the 6 strategies or the 6 drivers or the 6 enablers that CMS in particular, but the Department of Health and Human Service has to try to change healthcare quality and value and to move it in the direction we all want to see it go. So it's not limited just to payment systems. The first strategy is what I call contemporary quality improvement. By that, it's the traditional quality improvement where we measure a problem, we identify a problem, we try to do something about the problem, we remeasure, and then we reassess and decide what to do. But contemporary quality improvement goes a step beyond that, because many of the efforts we've done over the years have been without evidence-based medicine or evidence-based interventions. So contemporary quality improvement entails the absolute necessity to have evidence-based metrics and, more importantly, perhaps evidence-based interventions to try to drive better quality and better efficiency in the healthcare system. We can no longer afford to just make brochures and hand them out. We can't afford to use our best judgment and spend literally millions, in some cases billions of dollars to try to improve quality of care without having some sense that we know what we're doing in advance before we apply it to a broad population, certainly on a national level like we deal with at CMS. And that's what the Rogosin Institute, I think, is about in part. It's not only taking care of patients, but it's collecting information, evidence, and dealing with these patients in a very patient-centric and evidence-based manner. The second strategy, very important one that's come to the fore the last few years, is transparency. And that entails 2 specific functions in my mind. One is public reporting, so it's making data available and comparing various providers, services, treatments, any number of issues that first and foremost patients and their families need to be able to choose where they seek their health care, as well as informing them what the best treatments are. But it also entails making that data available to the broad general public. We have tons of data at CMS that have been collected for decades now, but arguably that data has not been easily available even to people working at CMS and at HHS, let alone folks in the field trying to take care of directly of patients. So I think you're going to see an incredible effort by this administration and by those of us that are career employees to collect even more data, but more importantly, to make that data available both by public reporting, but just by data availability. The third strategy are incentives, and we'll talk more about that, but this includes value-based purchasing, so-called pay for performance. Before you can get to those complicated structures, you have to collect data. So we have a number of pay-for-reporting projects and initiatives that have been ongoing for some time, which lead on to pay-for-performance, and we'll talk a bit about those. We should not forget, though, what is probably not always remembered and often seen in an onerous standpoint, but it can be a very positive driver of improved quality, and that are regulatory vehicles. I have here COPs, stands for Conditions of Participation. So my office, in fact, has a group that full-time, we have about 25 people who write regulations for the 17 different provider sites in the United States that provide care if they're going to be paid by Medicare. And frequently, if Medicare doesn't certify them, other payers will not pay them. So we have a tremendous leverage point here by setting minimum standards for quality under the conditions of participation or conditions for coverage. And that includes the dialysis world and the transplantation world, among others. And that's aligned with the survey and certification process, which then surveys facilities to see that they are in conformance with those minimum standards. We have national local coverage decisions. We can decide what devices, treatments, services actually are covered. This is independent of payment systems. So if for instance, there's a new dialysis technology, we can be involved with the rapid development and hopefully payment for those that work and add value to patient care. And at the same time, we have a responsibility not to pay for those and waste money that don't provide improvement for patients. And then last, but certainly not least, we're on the cusp of a whole series of demonstrations, pilots, and research that need to be done going forward. And we'll talk a bit more about that also. So before we get into the Affordable Care Act, I have to remind us all that there are many, many efforts from various pieces of legislation over the past actually 40 plus years. The Civil Rights Act of 1964, there are still elements of that that have not been implemented yet and are still being implemented at a very sporadic kind of point. But more notably, over the last 7 years, starting with the Medicare Modernization Act in 2003, there have been almost an annual health care expansion of payment and services or focus on quality and efficiency. And the one to our community in the kidney disease world, the Medicare Improvements for Patients and Provider Act of 2008, Section 153, provides for first a bundled payment reform for dialysis services. That's in Section B, 153B. And then ultimately a quality incentive program that will follow a year later. The bundled payment one, I've been checking even my BlackBerry this morning because you will be hearing a final rule very soon. Public comments have been reviewed over the last few months. And again, very soon you will be seeing a final rule being put out on the bundled payment reform. That will be enacted January 1st, 2011, so a short 6.5 months from now. It will be in effect and phased in over a period of years, as you'll learn. And there are grave concerns by some, widespread concerns by many, and I've listed for some of these for you. And you will see what the kidney community and the broad healthcare stakeholder community has been utterly fantastic in working with CMS, providing comments. And compared to the initial proposed rule, I think you're going to find that the final rule for the bundled payment reform will address many of the concerns that people had. Undoubtedly not all, but many, many. I think people will find this is a much improved final rule when it comes out. And I'm not going to go through all of these concerns, but these are probably well known to many of you in the room. A year following this, January 1st, 2012, we have to implement what is actually the first value-based purchasing program on a federal level in the United States. And for better or worse, good times and bad times, as Dr. Smith mentioned, the renal community is the first one out of the gate with a value-based purchasing program. So this so-called quality incentive program will be the first value-based purchasing program that CMS will implement on a national basis. The proposed rule that will outline what will go into this program is in clearance. You will also see that issued, I hope, relatively soon, not in the next few days, but certainly over a period of weeks to the next month or two. This is going to set precedents for all of our value-based purchasing programs. If you look back at the hospital value-based purchasing program from 2008 that we sent a report to Congress in 2008, it will give you some ideas of the framework, but I would suggest you just wait for the proposed rule. And then we will need together, as Dr. Smith alluded to, public comment is incredibly important. It can change final rules, and more importantly, it creates a dialogue among stakeholders with CMS to improve on any proposed rule that we put out. There are elements that the Affordable Care Act will add to this, and again, I've listed concerns that people have in advance. We just don't have time to talk about this fully this morning. Linked with this is our Renal Crown Web program. You know, you can't implement quality improvement if you don't measure quality. And we have measured nationally with national statistics or regional statistics the quality of care in renal disease for decades. We're arguably far ahead of any other part of the healthcare stakeholder system. However, we have not gotten down to broad metrics at the individual provider level, whether it be the individual dialysis facility or individual physicians or nurses or other caregivers. so that we had embarked a number of years ago and are getting very close to fruition for full national implementation, certainly over the next year, of the Renal Crown Web System, which is a single interface with the internet to provide, right now we have up to 26 measures that we could be requiring from renal facilities via this internet-based system. We're working with a number of problems, most notably security issues that we, CMS, are held to. And that should be completed by late this year. We've also been working, people are upset because a single user interface requires quite a bit of staff time to enter the data. So we've been piloting batch submission with the large dialysis organizations. And in fact, on June 21st of this year, we'll be beginning discussions with the National Renal Administrators Association to in fact have a batch submission organization that will be available to smaller dialysis organizations, not linked in with the 3 large dialysis organizations we've been piloting to date. I think we'll get back to this. Measures in the future are one of our main challenges in the end-stage renal disease world. So that's what we're dealing with, which has already been there, and there's many, many other things I could talk about, but that's the main, the MIPPA Section 153 is the main existing legislation that will affect all of us in the very, very near term. But that's just the beginning, and it's just probably a minor part of what we're embarking on because of the Affordable Care Act. This, as you know, took over a year of debate. It's very disappointing, I think, to all of us that it took so long, but it finally got done. And regardless of your personal feelings about this law, my own is on the optimistic side, as Dr. Smith was, I think, trying to express himself in his opening remarks. Everybody, if you want to really be on the cutting edge, this bill is not PPACA or PACA. That was the original bill that the Senate passed, but you may recall that the House then tried to reconcile things with the Senate version of the bill. They passed what's called the Healthcare and Education Reconciliation Act of 2010, or HACERA, and then the combination of those two led to what the President signed in a bill, which was the Affordable Care Act of 2010, or ACA. So it's not PPACA, it's ACA, Affordable Care Act. And this is Affordable Care Act 101 in 2 slides. There's 10 titles. It was originally over 2,000 pages. The condensed version that's out now is about 987 pages. I've read it about 4 or 5 times. Every time I read it, I learn new things that I didn't remember reading the first time around. You find all sorts of incredible little things. The best one I found so far in Title I, which has to do with patient rights and things, there's a section that talks about non-discrimination, that all of us can't discriminate against patients for a variety of reasons. Obviously, gender and sex and race and ethnicity is always in bills like this. But the interesting one that was added was that, and I hope I don't offend anybody who feels strongly about the Second Amendment, but there is a section in there where you cannot discriminate against patients who want to come into provider care settings and want to carry a weapon with them, as long as it's in conformance with state law in the area. So there's all sorts of detail in this bill. I've listed for you here the main titles. There's 10 of them. Public programs, expansion there. Improving the quality and efficiency of healthcare, which is Title III, is the largest section here. And I wish we had more time because this is the most interesting section. Title IV has a very, very heavy focus on prevention and wellness and public health issues. There's a tremendous section on healthcare workforce, expanding the number of training programs and funding for SANE to improve and multiply the healthcare workforce. Transparency and public reporting, improving access to innovative medical therapies. That's something that will be very important to us. Title VIII is a very interesting community living assistance services and support, the so-called CLASS Act. This is trying to keep people in the community not having to go into institutional settings like skilled nursing facilities for the rest of their lives. We don't have time to talk about it, but it's a very interesting title. Title IX, we were talking at dinner last night, and I think several people said, so how are we going to pay for all this? I haven't figured that part out yet, and please don't hold me responsible for it. But the Title IX section, there are revenue portions of this, where the bill, in terms of the Congressional Budget Office and our actuaries, there are savings which will pay for a significant part of this, but whether it pays for everything, I think, still remains to be seen. And then Title X are the amendments that were added afterwards. I have a whole series of slides that go through each of these titles, and again, we just don't have time this morning to go through each of these individually. Although I will, on Title III, Improving Medicare, the most important sections, just to highlight, Section 3001 is we are charged with starting a hospital value-based purchasing program by the beginning of 2013. As you can see here, the mandated measures will focus on outcomes, particularly for heart attack, congestive heart failure, and pneumonia. There's going to be a focus on surgical care and surgical care improvement, the SCIP program, hospital or healthcare acquired infections, HAIs, and HCAPS is the Hospital Patient Experience of Care Survey, which will also be a primary focus. There's a mandate for efficiency measures, although they are not specified. This means what do we get for the dollars that we're paying? We will have to come up with those. Public reporting is a major part of this, and they'll be separating out small critical access hospitals, CAHs, and other small hospitals that otherwise wouldn't qualify to participate in this value-based purchasing program. So we all participate in hospital care of patients. This is going to change radically the reimbursement and the way care is delivered, I suspect, in hospitals. Section 3002, Physician Quality Reporting Initiative. There'll be improvements with this, but the main part of this slide is we have given incentive, that is bonus payments, to physicians who have reported the last couple of years to the Physician Quality Reporting Initiative. But what Congress has done in this program and has done in other programs is to phase out the bonus and then to start withholding payment for people who don't participate. So as you can see here, by 2015, physicians not reporting data to the Medicare and Medicaid, well, Medicare program initially, will actually have a reduction of 1.5% and subsequently 2% of their payments going forward. So that's another, just an aside of what Congress has been doing with some of these payment systems. There's a feedback program to physicians telling them how their resource uses are. This needs to be done by 2012. There's quality reporting for long-term care hospitals, inpatient rehab hospital, hospices. There are value-based purchasing programs mandated for skilled nursing facilities, home health agencies, ambulatory surgery centers. There are payment adjustments for conditions acquired in hospitals where people will have payment reductions for certain conditions, particularly healthcare acquired infections that are reasonably preventable. There's a national strategy that I'm involved with and a number of other leaders at HHS with setting national priorities and developing a strategic plan by January 1st of 2011, again 6.5 months away. And you can see all sorts of focus here on chronic disease, quality, efficiency, websites, public reporting, etc. And it goes on and on and on in terms of details for just improving Medicare. A CMS Innovation Center, which has been established already, but the details, and you can see it'll be focused on rapid piloting of demonstrations, Medicare shared savings programs, pilots on payment bundling. We're already getting that in end-stage renal disease, independence at home demonstrations, hospital readmissions reductions, community-based care and transitions of care focus, gain sharing demonstrations. It goes on and on and on. And if you go to other, this is prevention and public health mandates. There's a national strategic plan that needs to be done for prevention and public health services, independent of the other strategic plan for quality that I mentioned to you. The healthcare workforce, I've mentioned there are grants for that. There's mandates for transparency, public reporting, and availability of data to the broad public. Access to innovative services. We cover payment for new innovative treatments and services, but FDA has to go through the safety and efficacy evaluation first, so we're going to be working more closely with FDA, trying to bring new technology to market more rapidly. I mentioned the Class Act and the revenue provisions. So many, many details which we just don't have time, but I hope you have at least an appreciation for the breadth of things. And CMS is ground zero for this activity. Almost every title and section is something that CMS, if we're not leading, we're involved with. So we have a lot of work to do. And to do that, we don't have the manpower, nor we have a lot of talented people, but we need public input, and we need to partner with all of you and many, many other people in this country to get there. So the Affordable Care Act, I've listed here on this slide what I think is the key content for chronic kidney disease and end-stage renal disease. I think there's going to be expanded coverage and access to care because of this bill. So although not all of our patients will have full coverage and full access yet, we still have a tremendous problem with the uninsured, particularly those who come legally or illegally from other countries and put a strain on dialysis service, particularly in other parts of the country, but also here in New York City. The Affordable Care Act will put a tremendous responsibility on all of us to collect more data and to report that data publicly. We've already talked a bit about value-based purchasing. We're already doing that in the dialysis world. But I think you're going to see some of the other areas that we haven't focused on as much include a focus on care across the continuum. So it won't just be care in the dialysis unit, or in the hospital even, for that matter, or in physician offices. It's going to be how do our patients navigate those various settings, as well as other settings, including skilled nursing facilities, the use of home health agencies, ambulatory surgery centers, and beyond. Healthcare-acquired infections, I've already mentioned. And I think there's going to be a tremendous focus on population health in addition to patient individual-centered care. So we're going to be very much more involved with obesity, smoking cessation, exercise, diet, immunizations, and any number of public health issues in the dialysis world, much more than we have been. And then finally, innovation in payment and delivery systems. So if we get to kidney care in general, what can we all expect from all of this? And again, the first few bullets here are perhaps repetitive. Again, if I haven't made the case clear, collection of data and reporting of that with the use of that data for multiple purposes will be necessary. I've outlined our strategies, and again, it's quality improvement, it's public reporting, it's incentive programs, it's looking at conditions of participation, so forth, all those 6 strategies that I mentioned. But here, let's get into, and this will lead into some of the other speakers as the day goes on, we will have to transition clearly to electronic health records, as well as the use of registries and other data sources. I think that we are embarked on the HITECH Act, another act, with providing an incentive program for the adoption of electronic health records in hospitals and in offices of eligible practitioners, physician offices primarily. There'll be a huge amount of money that's being invested in that. But notice that Congress has not enacted incentive programs for the adoption and interoperability and meaningful use in other settings, including dialysis. So I think the Rogosin Institute has been a leader in the development of electronic health records for the dialysis world. And that is going to pay off because we will have to push the Congress and push policy makers to include these other areas, including the dialysis world and the chronic kidney disease world. It's absolutely essential that we start linking electronic health record technology with the other focus that the Congress has chosen to focus on in hospitals and physician offices. Improvement in quality outcomes. I think the EHRs are fine, but we have to use their full potential. Again, I think many of you who are working here at Rogosin in particular have been experiencing the benefit of EHRs, whether it's decision support or other technical assistance that these provide, as well as the communication capabilities, at least within the small community that you have here. But we're going to have to link that with the entire healthcare world. I think that we're going to see more and more accountability. Up until now, people have claimed accountability when they know they've done a good job. But when they haven't done such a good job, the fingers start pointing. And it's always somebody else's fault, and/or we always have the sickest patients. And the risk adjustment doesn't pertain to us. So I think that we're going to have to get our arms around how are we all accountable in this system? Are we accountable individually? Are we accountable as a group? And we have to take responsibility and take accountability going forward. I think that the small independent cottage industry, that is small one-man, two-man, two-woman physician offices, and I'm afraid, except in areas where there is no choice but to have small dialysis units that are not somehow integrated with the rest of the system, have been outdated for a number of years. But the changes we're going to undergo with the Affordable Care Act really put the pressure on us to, if not in a full manner of integrating the healthcare system, we're going to have to virtually integrate. And again, I think that organizations like Rogosin and other smaller integrated systems are setting the way for us going forward. The accountable care organization model is very intriguing. I don't fully understand the definition of an accountable care organization. We're working on that right now. And this is an intriguing concept, though, that I think has great promise, but we're going to have to experiment with it. Again, forming some integrated system with a number of providers working together, all accountable for the care of a group of patients. And I think in the renal world, many people in this room, including myself and others outside the room, have been saying for years of what an opportunity we have in the renal world to, in fact, demonstrate for other disease states or the general population on how care can, in fact, be managed by a group of people working together, perhaps coming together to form an accountable care organization. So we are mandated with setting up a number of these demonstration programs, et cetera, and we at CMS are very, very, very much interested, and it's no mistake that because I'm there, I've been able to push this to include chronic and end-stage renal disease as a focus for at least one model of accountable care organizations going forward. So that's something I think we can look forward. And when I think of an accountable care organization, I don't think it's just, if you talk to large dialysis organizations, they're kind of thinking about the dialysis facility as the core, and how do you provide care for dialysis patients. But I think the model you have here at Rogosin is incredibly applicable to what I've been thinking about for years, which would include physician offices, it includes the dialysis facilities, it includes home training programs, fistula maintenance programs, transplant programs, CKD prevention and management, end-of-life and palliative care, and it includes interactions with all the other care settings, hospitals, nursing homes, et cetera. So trying to devise a system that we can do all of that and then expand it to be applicable in other parts of the country, I think is terribly exciting and something that's going to lead to improved care for chronic and end-stage renal disease. We're already embarked on payment systems reform, and we're going to see more of that, and we'll need to work together because the margins are so slim. If we don't get this right, we can negatively impact the end-stage and chronic kidney disease world. So we need your help and input. I think that patient-centered care needs a resurgence. And in fact, we were talking last night at dinner that a number of the new folks who've come in the administration, not wrongly, but they are very much focused on population health. And we do need a resurgence and a focus on population health that has not occurred in this country for a long time. But we should not, what I am concerned about is that in focusing on that, that individual patients and their special needs may get neglected. So we have to constantly remember that we have to keep a focus on patient-centered care. And I've listed a few things: health disparities not being addressed, challenging and difficult dialysis patients, still a problem and growing. End of life and palliative care. We had a setback with the death panel debates of last summer because people now are afraid to talk about palliative care. But we need to talk about that and do something about it. And then what are the patient responsibilities? You know, we talk a lot about focusing on individual patient care, but what should we be asking of our patients and their families? And again, I think there's a number of interesting projects that Rogosin has been involved with that too. Quality and value measurement development. We have multiple programs at CMS that are primarily pay for reporting. I've listed them here with bullets. I have to tell you about our most worst acronyms in the history of the world. RACTAPU is the first one there, the reporting hospital quality data for annual payment update. HOPQDRIP is the hospital outpatient, you know, PQRI and the rest. But these are all set up by Congress, and we need to align these and come into one aligned system where the incentives are clear for people, the responsibilities are clear, the metrics are shared. We don't have different metrics for different programs, and we get this all aligned as we go forward. Clinical issues that need more attention: cardiovascular disease. We haven't focused on that enough, certainly in the dialysis population. And I've begun work with a number of entities that hopefully over the next couple of years we will focus more on developing metrics so that volume status and fluid status will be measured, and we'll do something about that, because I think arguably that's probably our biggest challenge in the near term. Vascular access, anemia management, adequacy, mineral metabolism, these are obvious to you who work in this. And then the other clinical issues that we need to pay more attention to have to do with mortality measures, home dialysis, frequent dialysis, availability of transplantation option, the unique world of pediatric nephrology, which always gets second shrift and needs to have more attention paid. Medication and treatment compliance, one of our biggest challenges that we've done very little for, although I suspect you all here have worked on that more than I am aware of, and I'll love to hear about that. And then lastly, another area that I remember talking about when I came out of my fellowship, but measuring the functional status and patient experience in the dialysis world is something that we have not tackled, and we need to get on with very soon. We still have people, as you know, who, although they're getting these expensive treatments, are not able to go back to work or to live meaningful lives as much as they should. So I'm going to end with a modest collaborative proposal, which I think the rest of the day actually gets at. And that is, I think those of us in the chronic kidney disease world, and by the way, that has become so much more important now. CMS focused on end-stage renal disease. We've got 400,000 or so patients on dialysis. We've put a lot of money and challenge into that. But the 25 million Americans with chronic kidney disease, the agency now needs to focus on those people who are equal to or outnumber the number of diabetics who get far more attention. And we need to define, I think, a 5-year strategic plan for chronic kidney disease and end-stage renal disease, linking the care between those two across the continuum. And that's problematic because, as you know, Medicare pays for end-stage renal disease, but it doesn't pay for chronic kidney disease unless you're a Medicare beneficiary. So this gets to be very complicated. I think we have to outline how we can achieve widespread electronic health record adoption in the renal world, the nephrology world, and how we link that, more importantly, with the rest of the EHRs that will be in the rest of the healthcare system. I think we have to assess our current quality initiatives, particularly in the chronic and end-stage renal world, but we have to look at things that maybe we should declare victory. We're doing a pretty good job with dialysis adequacy. Frankly, except for some fine-tuning, we're doing a fairly good job with anemia management also. But there are many other areas that we have not addressed and we probably should pay more attention to, and I've listed a few here on this slide. And then on the last slide here, I think that patient-centeredness needs to become a higher priority with implementation of the CAP survey, more functional status measurements, looking at health disparities, which we have not really addressed in any sector of the healthcare system, let alone the dialysis world, and which may be worsened with our bundled payment system and quality incentive program if we are not careful. We have to define better what modality of treatment for patients who hit end-stage renal disease or who are approaching end-stage renal disease. What's the best treatment for them? I came out of my fellowship, there were great hopes that peritoneal dialysis was going to grow. It hasn't grown at all. In fact, it's less prevalent than it was in 1982 when I finished my fellowship. And we still don't really know what the best treatment for each individual patient is, and we should better be able to define that. And then there are challenging patients and treatment compliance we need to address. And then last but not least, these alternate reimbursement systems, we need to work together to look at how we can improve the quality and efficiency of care, with the accountable care organization perhaps being the most optimistic one for the short term with our sitting down. So I want to thank you very much for your attention here. This is only a smattering of what we've started on at CMS. I've been able to carve out to be here the entire day. I welcome any one of you coming up and asking me questions or complaining or berating me for whatever you'd like to. I'm used to that now, and I do listen and will try to respond if I can. Again, thank you for inviting me, and I think the rest of the day will be very, very interesting. Thank you.